us. The featured topic today is research into your role. Our first session will be presented by Dr. Patricio Millar and Mr. Jose Martinez of NYU's Dysautonomia Center, along with MSA&J board member, Dr. Lucy Norcliffe-Kaufmann. They will be discussing different approaches to research and advancements in diagnosis and disease management. The second session, presented by Robin Riddle, CEO of the Brain Support Network, will focus on the value of brain donation in not only confirming diagnosis, but also its importance to research. We hope you find these webinars helpful and informative. Thank you to our presenters and attendees for your continued support of MSA&J.
So
welcome everyone. Sorry. I just want to remind everyone that the session is being recorded. All right. So, you're aware if you want to change your name and write it in, rename as anonymous, you may do so. That's up to you. But I just want to make sure everybody is reminded. All right. It's my pleasure to turn this over to Dr. Lucy Norcliffe-Kaufmann. Thank you, Lucy, and thank you everyone for being here today.
Good morning, everyone. We are delighted to welcome you to kick off MSA New Jersey's series of lectures. I'm here today, this morning, with two of my esteemed colleagues. We've planned a session for you that will hopefully explain some of the basics of research and give you the information you need to make decisions about what kinds of treatment trials or studies that you might want to participate in. So it's my great pleasure to introduce Dr. Patricio Millar. Patricio is a faculty member now at the Dysautonomia Center of NYU. He's a PI of studies in multiple system atrophy. He's a neurologist that is highly trained in movement disorders. He's now got a lot of experience in working with patients with MSA and managing their various issues in blood pressure and other autonomic dysfunctions, as well as guiding people with MSA through their journey. He's going to tell us today about clinical trials and give you the information that you need to know. So with great pleasure, here's Dr. Patricio Millar. Thank you.
Hi, thank you, Lucy, for your introduction. It's a pleasure to be here again at the MSA Coalition lectures. So let me share my screen now and show you a little bit about what I'm going to be talking today.
I'm very sorry to interrupt. We're MSA New Jersey, not the coalition.
MSA New Jersey. I'm very sorry to.
Nope, that's okay. And I'm also sorry I butchered your name in the introduction.
It's still a pleasure to be here.
Well, I appreciate it. I just wanted to make the distinction. I know there's a lot of confusion about our relationship because we work very closely with the coalition and partner with them, but we are separate entities. So I'm sorry, continue.
No problems. Okay, so what I'm going to be talking about today is about clinical studies for MSA, for multiple system atrophy. So we're going to talk about what is a clinical study, what kind of clinical studies are there, and what we have learned from them so far. So first of all, let's go back. A clinical study are research studies in which the goal is to add knowledge about normal physiological processes or medical conditions. And grossly speaking, we have two types of clinical studies. We have observational studies, which look at how a medical condition starts, what symptoms appear or when do they appear, and how do they progress over time while a patient is receiving the best medical treatment available. Whereas interventional studies, also known as clinical trials, are looking at how a medication affects the symptoms or the course of a disease. Now, within interventional trials, we also have two categories. We have medications that are going to be for symptomatic improvement, meaning that they will make you feel better or treat complications of your disease. And we have disease-modifying medications. So these medications try to look at slowing down or arresting the progression of the disease. Now, observational trials are like setting up a base camp to study the road and to prepare. So we know what to expect from the trail ahead. And interventional trials is putting that training into practice towards reaching the goal of getting a better and longer life. So the key success in clinical trials, and we're going to be going over these key points from now on ahead, is identifying participants in the earlier stages of the disease so they can get the maximum potential benefit from any intervention, trying to target symptoms that are meaningful or problematic for the patients, and making sure that the interventions are safe, meaning that the benefits outweigh the risks. Also, it's important to know what to look for to quickly detect changes and making sure that the interventions that we're trying are effective. And the way that we get to know and to identify all these key points is through observational studies. So as you may know, we have our own MSA natural history studies. So observational studies are also called natural history studies because we look at how the disease progresses naturally over time. And using the natural history study of synucleinopathies with collaboration with many centers around the United States and around the world, we have been able to look at some data from patients both with MSA and who had conditions that precede the onset of MSA. So we do that by looking at clinical evaluations, demographic data, different physical examinations and tests to standardize all of these measurements. And again, to look at what symptoms appear in MSA, how did they progress, and how did they affect your quality of life. So what results have we seen from the natural history study so far? So back in 2017, we published a cohort of 74 patients that only had autonomic failure. They only had neurogenic orthostatic hypotension. I'm going to be talking about that in a while. And we see that many of these patients end up developing movement disorders. So around 25% to 1/3 of these patients end up having more problems than just the low blood pressure. Around 1/3 of them had Parkinson's disease. Another proportion of them had dementia with Lewy bodies. And again, another 1/3 had multiple system atrophy over a period of 4 years. So we've now expanded the cohort, and we have around 133 patients that initially started only with neurogenic orthostatic hypotension, but we'll follow them through 8 years. And we see that these proportions still maintain. We see that about 1/3 of these patients that only start with pressures with low blood pressure problems end up having some kind of movement disorders. And about 1/3 of them end up having MSA. So this has helped us determine how the earlier phases of MSA start, so we can detect these changes earlier, how we can identify this condition in the earlier stages. So what features in a patient with only autonomic failure with low blood pressure when standing could be signs of the prodromal or premotor phase of multiple system atrophy, meaning before the motor symptoms start? So as I always mention, this is not as simple as diagnosing any condition, for example, like diabetes or hypothyroidism, where simple blood tests can help determine very accurately if their condition is present or not. But we need to do a little bit of detective work and put together many features together. So we know that comparing to patients that only have low blood pressure problems and they stay like that, or patients who go on to have any of the other conditions like Parkinson's or dementia with Lewy bodies, which in the beginning are very similar to multiple system atrophy. Patients who go on to develop MSA usually start in their early 50s or 60s. They have more of a central kind of autonomic failure, meaning that it's not the autonomic nerves that are affected, but it's more the brain centers that command those nerves. They usually have early urinary bladder dysfunction and what we call RBD, REM sleep behavior disorder. This is a dream enactment behavior, acting out your dreams while sleeping, as well as a preserved sense of smell. Now we know that usually all of us do have a normal sense of smell, but we see that patients with low blood pressure who go on to have other conditions like Parkinson's or Lewy bodies, or even those who don't develop anything at all, have an affected sense of smell, which is also indicative that there's something going on in their brain as well. So this helps us, again, identify one of the key factors for clinical trials, identifying participants in earlier stages to try to get the maximum potential benefit of these interventions. Now, again, looking at the natural history study, we gathered around 377 patients with MSA from around the US and the world. Around 2/3 of them have the Parkinsonian type, and 1/3 of them have the cerebellar type as well. And what we learned is that when we look at one of the scales that is most widely used around the world to look at symptoms and symptomatic burden in patients with multiple system atrophy, which is called the UMSARS, the Unified Multiple System Atrophy Rating Scale, we see that even though this is quite good at detecting changes in the first years of the conditions, as the disease progresses, we see that the scores don't change so much. But we see when we evaluate the patients and when we speak to the patients that their disease is in fact progressing. It hasn't come to a standstill. So we see that there's this kind of a ceiling effect. We have two parts of this scale in which we look at, let's go back, in which we look at non-motor symptoms like low blood pressure, like constipation, urinary dysfunction, or how they affect their daily life. How does this impact in their gait, the way they walk, how many falls they have, how easy it is for them to use hand dexterity. And again, you can see that these changes are more prominent in the first years, but then the scale is not able to detect changes past a certain point. The same thing happens with the motor part of the scale when you do physical neurological examinations. We see that the changes are most prominent in the earlier years, but even though we know, because we evaluate the patients and we speak to them and they tell us about their daily experiences, that the scale is not able to detect those changes. So we need to do something about that. And it's not all good or all bad about the scale. Sometimes less is more. And we know that when looking at particularly disease progression, how MSA is affecting your nervous system, we see that there's a certain number of items that are particularly good at detecting your changes over a period of time. But when we start adding up other items, we see that actually there's like some form of improvement. And this doesn't mean that they're like bad items or that they're inadequate. This just shows you that certain items are better at detecting how symptomatic treatment affects your daily life, how they improve your actual symptoms. So for example, we see that medications for low blood pressure, of course, they will make you feel better. You will feel less dizzy, less lightheaded when standing. But we see that they also improve measures of gait or walking or balance as well. So this is how we need to adapt these scales and design new scales to better reflect what we want to look at individually. So to know what to look for, to quickly detect changes, to know that the interventions that we're looking for are effective for you. So we know that up to 80% of patients with multiple system atrophy will have blood pressure problems. The vast majority of them will have low blood pressure problems, and 2/3 of them will have supine hypertension, high blood pressure when laying down. And we know that this is a risk factor for multiple system atrophy. So this also helps us making sure that the interventions that we try are safe. We always want to see that the benefits that we get from these trials for these new medications outweigh any possible risks. And this will come in important in a moment. So taking together our natural history studies, we're developing a new study called Track MSA. We're trying to track the symptoms of multiple system atrophy and the progression over time, so we can know what to expect and when to look for when new medications come available. So we're able to quickly realize if these medications are actually effective for you. And we're doing this in collaboration with the Innsbruck Medical University. And we look at patients with multiple system atrophy at an entry point, 6 months, and after 1 year. And we look at biomarkers of disease progression and symptomatic burden. We look at clinical evaluations, neurological evaluations, as well as questionnaires that assess how different symptoms affect your daily life and your functioning, how burdensome are they for you, as well as using wearable devices to more accurately track your symptoms, and using MRI to try to develop new imaging sequences that will enable us to earlier diagnose MSA and to quickly detect how the disease is progressing, as well as using blood and cerebrospinal fluid to look at how the disease is affecting your body. So if you want to participate in the TRACK MSA study, if you're interested or if you have any questions, you can contact our clinical trials coordinator, Jose Martinez, who will speak in a moment, and he will be able to tell you more about it. Now, moving on to the next point, trying to target symptoms that are most meaningful and problematic for patients. So once more, we said that up to 80% of patients with MSA will develop blood pressure problems, low blood pressure when standing, which is called neurogenic orthostatic hypertension. And this can have a significant impact of quality of life, particularly because even with treatment, a vast majority of patients will still have symptoms of low blood pressure. And this can be quite significant in your quality of life, because we know that as your blood pressure starts going down when you're standing, you'll start having symptoms of dizziness, of lightheadedness. You'll start having visual changes, visual disturbances, auditory disturbances, problems concentrating, pain in the back of your head and your shoulders, which we usually call coat hanger pain, muscular fatigue and weakness, and ultimately fainting as well, which can lead to falls and risk of hurting yourself. So going back a little bit about a more scientific explanation of what is neurogenic orthostatic hypertension. Hypertension is low blood pressure. Orthostatic means when standing, and neurogenic means because of the nerves. So we know that usually when we stand up, the blood starts pulling down your body through gravity down to your legs. So what your body does is, through the autonomic nerves, it secretes norepinephrine to cause vasoconstriction. So we know that your norepinephrine levels increase from laying down to standing, and this vasoconstriction allows you to keep an adequate blood pressure when you're standing upright. Now, what happens in neurogenic orthostatic hypertension is that there is less secretion of norepinephrine, so there is less vasoconstriction. And we see that when you stand up, norepinephrine doesn't go as high as it should, and this in turn causes your blood pressure to go down. So medications that target neurogenic orthostatic hypertension, they usually act around norepinephrine and the norepinephrine receptors in the blood vessels. So for example, we have droxidopa, which is a synthetic amino acid that the nerves take up and they convert directly into norepinephrine. We also have midodrine, which is like a synthetic norepinephrine that also acts on the receptor to cause vasoconstriction. And we have fludrocortisone, which is a synthetic steroid that increases your intravascular, your blood volume, and it also helps the receptors respond more appropriately to the norepinephrine. So now we are developing new medications, a new line of medications called selective norepinephrine reuptake inhibitors. So when norepinephrine is released by the nerves, it is quickly reuptaked by the nerve to recycle it and use it again. So what these medications do is by inhibiting this reuptake here, the norepinephrine will last longer on the nerve. As you saw before, the neurogenic orthostatic hypertension, you usually have less secretion of norepinephrine. So this will enhance this action and harness the activity of the remaining norepinephrine. And for this ones, there's a medication called atomoxetine that was usually used for ADHD and has been repurposed as a medication to treat orthostatic hypertension. And a clinical trial for it has been recently finished. And we're trying to look at results, hopefully in the near future. There's another ongoing trial with a new medication called ampreloxetine, which has the same purpose. So I'm going to talk a little bit about this now, and Jose will tell you more about the trial when he speaks ahead. So this is a trial supported by Theravance Biopharma for the treatment of neurogenic orthostatic hypertension with this selective norepinephrine reuptake inhibitor. So this may be a particularly promising new medication for patients with MSA, because as I mentioned earlier, the problem in MSA is not so much in the nerves, but in the centers that control the nerves. So patients with MSA have more norepinephrine in their synapses, in their nerves. So there's more norepinephrine for the reuptake inhibitors to work with. And this trial was specifically designed for patients with multiple system atrophy. So there's always a big slot of enrollment placements reserved specifically for patients with MSA. And this is usually done in centers around the world that have an expertise in MSA and autonomic dysfunction. So again, we can make sure that your safety is ensured throughout the trial. One of the advantages of this medication is that it's long-acting. It's once-a-day treatment. The other medication that I was talking about, atomoxetine, is twice a day. Although sometimes this has its pros and cons. There's no one size fits all with medications. Some patients, for example, with swallowing difficulties, may prefer to take one-day medications. While in some patients, we often suggest for them to take medications, shorter-acting medications, so they have a better blood pressure support when they're doing certain activities. So the most critical element for any trial to succeed is, of course, the enrollment of patients, to have enough number of patients so we can evaluate the safety of the medication. We know that it's working for everybody, that it's safe, and that it's actually effective. But what about the pandemic? That's a cause of concern, and that's a cause for safety as well. So in response to the pandemic, both the ampreloxetine trial and many other trials had adapted through telemedicine. We quickly learned on our feet and developed new tools with home kits, hybrid visits, meaning some visits may be done through telemedicine, some visits may be done in the hospital, or a combination of both. And we have adapted these rating scales to be performed through video. So this enables us to do many of these visits or evaluation from your own home without the need to go into the center, which you know right from the start. But for some patients who may not live specifically close to the center, may be burdensome. Even more so if patients have movement problems, if they have problems with balance, with gait, and of course with low blood pressure problems or with urinary dysfunction. So this has enabled us to decentralize clinical trials, meaning that they're not conducted specifically at the centers. So we have more flexibility, and you can opt in doing remote visits in the clinic or in the center. And we can follow up patients remotely, and we can connect in person with investigators via video conferences. And we can do important safety assessments at home by trained personnel. So the way that these clinical trials usually work is we have screening visits to make sure that you are a good candidate for this medication, that this medication can actually work for you, and that this medication will actually be safe for you once again. If these conditions are met, you're enrolled in the trial, and then we can opt in and decide if you're going to conduct the visits either remotely or in the clinic. So in conclusions and to my close-up remarks, is that observational or natural history studies are now helping us to be ready for clinical trials, and they help us identify patients and diagnose patients at earlier stages so that they can get more benefits from any medications that we can develop. Talking about which, the TRACK MSA study is an opportunity to answer some of these questions about how to accurately detect if new therapies are working on you on a short period of time. And telemedicine is allowing us to progress in research without compromising your safety, and to being more comfortable from your own home without having the burden to travel to a center. And clinical trials like the atomoxetine trial, the ampreloxetine trial, are being adopted in response to the pandemic. So thank you very much for your attention. I know that sometimes we may get too technical or too little technical. So of course, if you have any questions, be sure to post them and we'll discuss them later.
Thank you, Patricio, Dr. Millar, for that great introduction to the session and the types of research and trials that are ongoing for multiple system atrophy. I'm here today representing MSA New Jersey, and it's my great pleasure to introduce Mr. Jose Martinez. Jose Martinez has over 25 years experience in managing patients with autonomic disorders through clinical trials. He has been working with the MSA community for a very long time. He celebrated his 10-year recognition award for his services to the Department of Neurology at NYU School of Medicine very recently. And he made some important contributions to helping understand MSA, particularly highlighting the roles of the high rates of depression in the population and how that might influence symptoms. So Jose today is here to tell us about the available clinical trials in multiple system atrophy. So Jose, take it away. Thank you very much.
Thank you very much, Lucy. It's a pleasure to be here with all of you. And I'm just going to share my screen now. So I just want to touch a little bit more on the two current studies we're doing at our center at NYU. The first one was the Theravance studies. So the Theravance studies are, like Dr. Millar mentioned, studies to help with a treatment for the orthostatic hypotension that approximately 80% of patients with MSA have. So the studies are in sequential 3 studies conducted by the Theravance Biopharma. And this is a diagram of the first study, which shows that patients come in with symptoms of orthostatic hypotension, symptomatic orthostatic hypotension, and then they get randomized here into 2 groups. One that would receive the active drug, amorpholoxetine, which is 10 milligrams once a day, or they get placed into a placebo group.
We're seeing, is anybody else seeing a blank screen? I'm seeing blank.
Yeah, Jose, do you just want to wait a second because your screen is blank?
Maybe click on it again. Maybe things are going to appear as you
Oh,
click.
let's try it again. Sorry.
No.
There you go. You see that?
Yeah.
Yes, thank you.
Sorry. So this is just a diagram of the first study. Like I was saying before, Theravance has created 3 studies to better understand this compound, the TD9855, also called praloxetine. The first study is very short. It's only 4 weeks in duration. There is a screening period to determine eligibility into the study. And then the subject will be randomized to 2 groups, an active group receiving 10 milligrams once a day, or a placebo group. In this study, there are 4 visits that are done, the screening, and then once a week visits that are done in the clinic, or now they can be done, like Dr. Millar had mentioned before, virtually with it. So at the end of this 4-week session, you would roll over, eligible patients would roll over into another group. This diagram just represents that we have the flexibility to do visits all at home. And let me speak to that. At the home visits, you have the option where you would either speak with the doctor or myself via Zoom, and also have a home health aide nurse come to your home to conduct blood draws, molecular analysis, and perform an ECG at home. Medications would also be delivered through either FedEx or through a courier system that the Theravance has provided. Once you've completed the first study, the 169 study, you would roll over into this longer study, the 170 study. And in this study, the first 16 weeks of this study is open label. So you are guaranteed to receive the active drug for the first 16 weeks of the study. Then at the end of those 16 weeks, you would be randomized either to continue to receive the active drug or enter a placebo group for 4 weeks. Sorry, for 6 weeks. At the end of that, you then have another option to enter even a longer term study. And this study is basically to determine the long-term safety of the drug. And this study is 162 weeks, so 3.5 years. You would be receiving the drug at no cost to yourself. So basically the completers of the 170 would be enrolled into this very long-term study, which is 162 weeks in duration. And again, in this study, same as the other two, there is the option of conducting most of these studies through telemedicine and with visiting nurse service at home, and having the study drug delivered via courier service to your home. The other study I wanted to talk about, which is the one we're conducting, we just started, is the TRACK MSA, which is an observational, non-interventional longitudinal natural history to define biomarkers in blood, in neuroimaging, and in CSF in patients with MSA, and comparing them from baseline at 6 months and at 1 year. So we are hoping to enroll 50 patients with either MSAP or MSAC, and this study is being done mainly at NYU, but also we have a collaboration with Innsbruck that's also being enrolling patients. And again, the study is to identify biomarkers so that we can, in the future, create more valid instruments of measuring disease progression in future trials with MSA. And this is just a diagram again of what the visits will occur. In this one, you do need to come to our center because this requires both lumbar puncture for collection of the CSF and also a brain MRI, which has to be done at the center. So, but there will only be 3 visits to our center, each 6 months apart. At baseline, 1 at 6 months, and 1 at 1 year, with phone calls or Zoom visits done at 12 weeks and at 36 weeks. For any future questions, you can always contact me at this number, and this is my email. So if you're interested, let's just send me an email, or if you have questions, just call or email me at this number. Thank you.
Thank you, Jose, for that great description of the trials that are available in for patients with MSA in the local area. So we are going to move now to the question and answer part, there is a Q&A box. Please, this is your chance to ask. This is your, you should feel free to type any questions that you would like to pose to the team within, and we'll be available to answer them for you. So I'm going to start with a few questions that were submitted. Dr. Millar, thanks for that great overview of the types of trials that are available. Frank and Barbara asked the question, do trials in MSA incorporate non-medical aspects such as vitamins or supplements and different forms of exercise? I know you touched on in your trial the possibility of developing drugs, but of course, non-pharmacological aspects are so important for MSA too. Do you want to touch on that a little bit, Dr. Millar?
So absolutely. One of the things we are looking, for example, in the TRACK MSA study, again, through different questionnaires and the use of wearable devices in the future, is regarding patient mobility, exercising, and the risk of falling, for example, during different situations. I also want to take the chance. I saw that also Frank and Barbara posted a question on the chat that is about Barbara's blood pressure dropping when standing, but she rarely feels weak or dizzy. And why is it that it has no effects upon her? And this depends on two factors. One is how low does the blood pressure get? So sometimes the blood pressure may drop, but it may not drop low enough. So we know that the brain is paradoxically quite smart, and it has its own regulation, its own way to regulate how much blood flow it gets. And it has a very wide range of what we call autoregulation. So between a broad range of blood pressures, the brain is able to correct and adjust how much blood flow it gets. So usually, if the blood pressure does not fall below 100/60, any patient will not feel any symptoms. And particularly in some patients, when they have a chronic low blood pressure when standing, their brains are able to adapt and to manage even lower blood pressures. So this is a good thing. What we also always try to emphasize the importance of screening for these low blood pressures, because then we can act on them before patients start having symptoms, or to avoid them from having complications like fainting and falling down. So this is a very good instance to try to put into place as much non-pharmacological interventions as possible, like drinking water, taking salt, doing exercise, using compression garments, for example.
Thank you, Dr. Millar. Now, there is, Jose, there's a question for you. Can you show the contact of the clinical study at NYC? Is it possible that we could post in the chat or in some other place on the meeting so that people can copy down your information and get in touch with you if they wanted to participate in one of the trials? Because I know you flashed it up. I just want to give people the chance to be able to take down that information. Here, let's move. I'm just moving over to the chat, and again, this relates to this is a question from Ella Wu. How much exercise is recommended? I feel low energy the day after 1 hour exercise with my trainer. Dr. Millar, do you want to take that question on?
Absolutely. So we usually recommend about 40 minutes to 1 hour daily exercise, mainly aerobic exercise. And one of the reasons that patients may feel excessively fatigued after working out may be that during exercise, there's increased vasodilation to improve blood flow to your muscles. So again, as vasoconstriction is impaired after doing exercise, your body may not be able to correct for that redirected blood flow, and you may have lower blood pressure after doing exercises. So for example, this is one of the situations in which we try to look at the blood pressure before doing exercise and right after doing the exercise, see if there are any meaningful changes. And for example, if any given patient may benefit from taking a particular dose of a given medication to try to increase their blood pressure after they do exercise, so they are able to go past this fatigue that they feel after exercising. And let me also say that exercise is a very big important of non-pharmacological treatments in MSA due to a number of reasons. So for example, one of the reasons is that it improves symptoms of orthostatic tolerance, meaning of the low blood pressure symptoms when standing. And this is because it helps with cardiovascular and muscular conditioning. To put it the other way around, patients that are sedentary start getting deconditioned. So it's kind of like saying, if you don't use it, you lose it. If your body is not used to tolerate any exercise, it will do the least minimum effort. So when it faces a little bit of a challenge, like standing up or going around, your symptoms will be more severe. Now, also, we know that a lot of patients with multiple system atrophy have problems with balance, with coordinations, and may put them at risk of falls. And one of the major complications for this is having fear of falling. So fear could be a protective instance in many situations, but also can be quite disabling. So many patients do have a fear or apprehension of falling. So this is why they become more sedentary. And this gets into a vicious circle in which patients become more sedentary. When they go around and they start doing activities, they have poor balance, more symptoms of low blood pressure, and they are at a higher risk of falling down and hurting themselves, which again feeds back into the circle and makes them more sedentary and putting them at higher risk the next time.
Thanks, Dr. Millar. Even though, are there specific ways in which patients can just generally work around adapting exercises if they have MSA? Do you have any thoughts on that?
Absolutely, and this is a great question. So again, like Ms. Wu was saying, some patients do have lower blood pressure when exercising. So if this is the situation, we recommend trying to use stationary or recumbent bicycles. So you're in a safe position to exercise and to work out, to make sure that if anything happens, you're in a safe position that you're not going to hurt yourself. Doing floor exercises, using a rowing machine, for example, or doing any form of exercise while laying down. Now, on the other way around, we have patients that have supine hypertension, and when their physical therapist comes home or when they go to do physical therapy, they measure their blood pressure and they get very alarmed because the blood pressure is high. But again, we know that if the patients sit up or stand up or do exercise, their blood pressure is going to go down. It's going to get lower and normalize. So this shouldn't be a limitation for exercise either.
Thanks, Dr. Millar. Our next question that came in it's very interesting because it touches on the patient journey, right? And I know that together we've done quite a bit of research in trying to help understand how MSA presents and how we might diagnose it. So my friend was eventually diagnosed with MSA after several years of thinking she had Parkinson's. Her first presenting symptom was dizziness, which the neurologist thought was due to a neuroma. In retrospect, she was experiencing orthostatic hypotension. Was she experiencing orthostatic hypotension typical of MSA? Do you want to touch on that, Dr. Millar? And maybe, Jose, you can talk about how patients might measure their blood pressure to detect whether they have NOH.
So that's a good question to try to see if this was actually symptoms of dizziness or orthostatic hypotension, because we know that one of the symptoms of orthostatic hypotension is dizziness, but it's not the source of all forms of dizziness. We know that some patients may be unlucky enough to have more than one condition, and some patients have, because mostly patients with a cerebral variant, they may have problems with balance coordination, and this also creates a form of vertigo or dizziness that is unrelated to blood pressure changes, but is related to posture, meaning that when they change positions, when they lay down or when they stand up, they start getting dizzy, and this may not be related to the blood pressures. So again, this is why it's so important to do check the blood pressure, both in symptomatic patients and asymptomatic patients. And in symptomatic patients, it's very important because even though they have dizziness like your friend, we need to know if this is because of the low blood pressure, because otherwise no matter how much medication to increase the blood pressure you give them, you're not going to get rid of the symptoms, and you're not going to be treating them appropriately.
Thanks for that, Patricio. Jose, I know you've been very involved for many, many years in helping patients identify whether they might have a fall in blood pressure with standing. Do you want to go over some of the simple things people can do at home with their own blood pressure cuff to check if they're suspicious that they might have a fall in blood pressure?
Sure. So one of the things we recommend, and now that we're doing many of the trials virtually, we are doing basically what's called the standing orthostatic test at home with either Dr. Millar or myself observing how they're taking their blood pressures via Zoom. So basically, we with just regular home blood pressure, you would put it on your arm, and you could either lie down for a 10-minute period, take your blood pressure twice after 5 minutes in a supine lying down at a 30%, 30-degree position. So it's not 100% flat. We want you at a 30-degree angle with your head up, the torso up at 30 degrees. And then after 10 minutes, we ask the person to stand, and we will take the blood pressure measurements at different intervals. At 1 minute upon standing, 3 minutes, 5 minutes, and even 10 minutes if the person can last up to 10 minutes. So we're looking to see whether there is a sufficient drop in blood pressure, and the standard that we use is the 20-10, so 20-degree drop in systolic and or 10-degree drop in diastolic over a 3-minute period. So if your blood pressure drops from the last blood pressure when you were supine to the 3rd minute of standing, and if there was a 20-degree drop in the systolic or a 10-degree drop in the diastolic, that would basically be defined as orthostatic hypotension. And whether now you feel symptoms is a different issue. So even though some people have even more than a 20% or 20-degree drop in systolic, they still may be asymptomatic. So it's like what Dr. Millar mentioned before, is how low the blood pressure goes, not so much how much of a drop there is. Certain patients that have supine hypertension can have very high blood pressure when lying down. Someone can go from, per se, 160 systolic and drop 30 to 130, but still at 130 systolic would not be symptomatic. So we usually see symptoms at when the systolic blood pressure drops maybe to under 100. Then people would start feeling the dizziness, lightheadedness, blurred vision that comes along with orthostatic hypertension.
Thanks, Jose. I'll have one follow-up question to that. And do you recommend that people take because what you're looking at, right, is changes in blood pressure, right? You're asking people to measure it lying down and standing up. Do you recommend they do it at particular times of day? Should they do it like with or without meals? What are your thoughts on that?
Well, obviously, certain individuals will be different. We know that meals, especially heavy meals, tend to drop the blood pressure even lower. So that's one thing we tell patients as well, that eating large meals, like large carbohydrate meals, will lower your blood pressure even more. So we usually, I think, recommend that people take their blood pressure, during the day, maybe at different times during the day, in the morning and then afternoon. And they can also take it while they're sitting, while they're sitting, and then just stand. They don't have to be supine to see how much of a drop there is. Also, if you take your blood pressure, right after you've taken medication, many people who have taken Midodrine or Northera, obviously those will have an effect. So we would want them to take it, not right after they've taken their blood pressure medications.
Thanks, Jose. And when they take, if people are doing home blood pressure measurements, there are a lot of numbers, right? You press the button, you get a top number, you get a bottom number, you get a heart rate. What should people write down?
Well, the two measurements that we're looking at is the systolic and the diastolic. So the top number is your systolic blood pressure. That will be the higher number. And then the diastolic is the lower number. But both are, those are the numbers that we really need. The heart rate will change also depending on the blood pressure, but that's not as essential as the two, the systolic and the diastolic values.
So thanks, Jose, for that. If anybody has any questions about how to measure their blood pressure or detect neurogenic orthostatic hypertension, please feel free to reach out to any of us and we'll be happy to provide guidance. We have a question that came in through our Q&A, which relates to the movement aspects of MSA, and it's my symptoms are asymmetrical. Left side weaker than right side. Dr. Millar, do you want to comment on that and some of the patterns of movement problems that we might see in patients with MSA?
Right. So we usually try to, with any medical condition, we try to make generalizations of these conditions, but we know that they're not often textbook, sort of speaking. That's the more classical thing. And for MSA, for example, we always try to look for symmetrical findings. But we know that in many patients, this is not the case, that there may be either a right or left-sided predominance. And even in some patients, we see that there's even an upper or lower limb. So some patients may have more problems with a weakness or coordinations with their hands than they do with their legs for walking, for example. So this is not an unusual finding. That part of the spectrum of manifestations of multiple system atrophy as well.
Thank you, Dr. Millar. And is there anything new on the horizon when it comes to helping patients manage their problems with movement?
So one of the things that we always try to do if the patients have predominantly Parkinson's symptoms is try with levodopa. So levodopa, like droxidopa, is an amino acid that gets converted into dopamine in the brain. So one of the things that happens in multiple system atrophy is that the structure, some of the brain structures that are related to movement, precision, and coordination are affected. And these structures receive their signals through nerves that secrete dopamine, much like your blood pressure problems are related to the nerves that secrete norepinephrine. So sometimes by increasing the dopamine concentration with levodopa, we see that some patients get benefit from different symptoms like tremors or rigidity, muscle stiffness, or coordination as well. But as we said, because the problem is not in the nerves that secrete the dopamine, but in the structures that receive it, compared to patients with Parkinson's, patients with MSA may need higher concentrations or higher doses of levodopa, or in many cases, they may not get a good response at all. And one of the best things, like I was mentioning, that is good for patients with MSA regarding movement problems is trying to maintain a certain degree of physical activity and physical therapy. So to try to adapt to the changes that they are presenting so they can use different strategies. So of course, when you start having a movement problem, it's quite interfering because you've been using that kind of movements, those sort of movements or strategies your whole life. So in a way, it's like learning to walk again or to use your hands again, just in a different manner. And this is when physical therapists and occupational therapists are very handy, because they're very good at observing these parts of movements and these problematics, and with providing solutions to better adapt your functionality to those specific purposes.
Thank you, Dr. Millar. Please let us know if you have any other follow-up questions to that. I see Jose Martinez posted his email in the chat. So if anybody has trouble and wants to follow up, please let us know and we'll be happy to get that information. I want to go back a little bit and talk about clinical trials, since our session today is about research. Jose, there's a lot of options when it comes to participating in clinical trials, right? Where can patients go to find accurate information?
Well, the best place to go, every clinical trial that's conducted in the United States, it's posted in clinicaltrials.gov. So in that website, you'll see, you just have to Google, once you're in the clinicaltrials.gov, you can just type in MSA, and a whole list of studies that are conducted for multiple system atrophy will populate, and you can see which studies are active. In addition, in that clinicaltrials.gov, they not only tell you what trials are there, but they also give you the results. So it's trials that have been completed. You would also see information about what the outcome of that trial was. So that also gets posted in clinicaltrials.gov. It tells you what studies are upcoming that maybe are just posted right now, but haven't yet start enrollment. It will tell you which studies enrollment are completed. So it's a very good website to see where not only current studies, but maybe even future studies and when they will be beginning.
Thanks, Jose. So once you've gone to clinicaltrials.gov, you see a study, it says that it's recruiting, right? What should be your next step, do you think?
Well, also in clinicaltrials.gov, it would also tell you who is recruiting, where are the sites located. They usually also they give you a contact information. So they post the principal investigator and also the coordinators actually for that trial, and contact information. So you will be able to email or call the site as well.
Thanks, Jose. So you field a lot of those conversations, right, with people calling up after they find out. I mean, they get your contact information as a senior clinical trials coordinator. What should patients be asking in those conversations when they talk to you? What's the best, in your mind, like what questions are useful to ask to learn about the trials?
I think one of the questions would be, what are the eligibility criteria? Because first, if you're interested in a trial, you want to know, first of all, right from the bat, whether you would be accepted in the trial. So you would basically want to ask any coordinator, what are the enrollment criteria for the trial, and then you'll be able to kind of determine, obviously, you'll get a general idea whether that trial is suitable for you. You would also want to know if it's a trial with new drugs, experimental drugs, you would want to know the side effects of those drugs. to, judge within yourself the risk-benefit factor. So you would want to get an idea of whether there were previous trials with that particular drug and whether there were any kind of side effects, what are the potential side effects. In addition to that, you would also want to know whether the trial provides any kind of compensation or travel, because many of these sites obviously might be in locations where patients have to travel to, and if they're far distances, you want to know whether the sponsor or there's any kind of reimbursement for travel costs or participation costs.
Thanks, Jose. And in that conversation, say you've chatted about and you think you might be eligible, you know the number of visits it entails. Should you ask for more information? Should you ask for the consent form? How can you, once you say I'm eligible, like how can you go that step further to make sure it's legitimate?
Once I speak to people over the phone, I generally have a talk with potential subjects. I explain to them in general what the study is about. Like I just mentioned, whether there's compensation for participating in the study to cover transportation costs and so forth. And then I would email them a copy of the consent. So the consent will have more detail about the study, and it would go actually through visit for every visit, what exactly is being performed at each study visit. Whether that would also be done at the site or through telemedicine. So all of those things are written in the consent form in great detail.
Thanks, Jose. The next question that came in, please keep the questions coming. We're here for you to answer them. The next question that came in was, I was wondering about thoughts on stem cell therapy treatment in response to in relation to MSA. Patricio, Dr. Millar, do you want to take on that question for us?
Yes, absolutely. So regarding stem cell therapy for multiple system atrophy, it's a quite interesting question, because the idea behind that is that stem cells produce certain neurotrophic factors that could slow down the progression of multiple system atrophy. And as a matter of fact, a couple of years ago, there was a publication of a group in Mayo Clinic that actually looked into this. So they injected patients' own stem cells into their cerebrospinal fluid, and they looked at how the disease progressed over time, comparing that to these observational studies, these natural history studies that we do. And they found that there was a certain reduction, there was a signal for improvement or reduction in progression of multiple system atrophy in that regard. But also there was a concern for safety, because of course, you know that stem cells can have the potential of becoming any cell in the body. And they looked at with certain doses or forms of administration of these stem cells, they could start adhering to the spinal cord or to the nerves and cause small tumors. So that was a big concern for safety. So of course, if you are considering in doing stem cell therapy for MSA, it should always be done at a serious center that is doing this as part of the research study, as this has not been approved yet for the treatment of multiple system atrophy, that they administer the stem cells in the correct way in the cerebrospinal fluid, where they are supposed to act, where they are supposed to have their most effective action. And of course, that this is done in the context of a clinical trial to assess, to look for, and to potentially treat for any of these complications that may occur.
Thanks, Dr. Millar. I have one important follow-up question to that. We all want better therapy for MSA, right? And we faced, should somebody be paying for stem cell therapy if there's an opportunity to get it and pay for it? What's your thoughts on that?
So number one, again, if you have to pay for stem cell therapy, that would be a little bit of a red flag on my behalf, because again, as this is not an approved therapy, it should be done in the context of a clinical trial. And like we were mentioning, you should never pay for a clinical trial if there's no data, no evidence that this is truly going to be an effective treatment for you and that it's going to be truly safe. Then of course any reactions that may happen, or any safety problems, or any surveillance that you may need to undergo for this therapy should be done at no cost to you at all, and should be paid for the sponsor of this trial as well. As again, there may be many centers or doctors that offer stem cell therapy, but may be directed to other conditions or administered in a way that will not reach the central nervous system where they would need to act if they are to improve symptoms of MSA and reduce the disease progression. So we know that stem cell therapy may be very promising in several fields and even in multiple system atrophy, but we urge you to be very cautious if you undergo any of these treatments, and to always do them in the context of a clinical trial to ensure your maximum care and safety.
Thanks, Dr. Millar. You, Jose, you touched upon in one thing you mentioned earlier about repurposing drugs, right? I mean, do you want to, both of you, just explain to us what are repurposed drugs and how they might differ to, for example, experimental drugs?
So a repurposed drug, if I understand you correctly, is a drug that's FDA approved for one indication, but then is used experimentally for another one. So that was similar to the atomoxetine trial that we just finished, which we just completed. And in that trial, atomoxetine, which is a drug that's FDA approved for attention deficit disorder, was also shown in studies that we had done in the past that it increases blood pressure because it is a neuroepinephrine reuptake inhibitor. So it increases the natural norepinephrine in one's body, and thereby increasing the blood pressure. So we conducted now 2 clinical trials with this compound to show that it's effective in increasing blood pressure in patients with multiple system atrophy and in other disorders like in Parkinson's and also pure autonomic failure. One of the good things about that is that since it's already FDA approved, even though it's experimental for this, you can get a prescription for it. So in fact, several of the patients who participated in the atomoxetine trial, once the trial was over and they felt that it was beneficial to them, they were able to get a prescription and continue taking the drug afterwards, after the trial was over. So that's one good way of showing that these repurposed drugs, because in a regular clinical trial, once the trial is over, you're not able to get it since it's not an FDA approved drug yet.
Thanks, Jose. That leads us on. There was a great question that came up in our chat, which is kind of similar to that, which is can multiple sclerosis drugs be used for multiple system atrophy? Dr. Millar, do you want to take that question?
Absolutely. So multiple sclerosis, it's more of an autoimmune disorder in which your own immune system is dysfunctional and is causing subsequent damage to your nervous system. Whereas in multiple system atrophy, what happens is that there is an abnormal protein aggregation that starts building up, and this causes an inflammatory reaction. So that's why multiple sclerosis medications would not be as effective for multiple system atrophy, as they target different systems behind the cause of each individual disease.
Thanks, Patricio. Our next question also came in through the Q&A box. Please keep them coming. We're here for you. Do you observe that midodrine may become less effective over time, and do you suggest increasing the dose? Dr. Millar, do you want to take that question?
Absolutely. So it may not be about the effectiveness of midodrine, but it may be more regarding the severity of the orthostatic hypotension. So that's when you may notice that the midodrine is not as effective as before. So this is a good opportunity to look at what's happening with your blood pressure before and after taking the medication, as in some cases it may be that it's not the medication that is not working, but there may be a reduced absorption of the medication. And again, trying to look at if there's room for increasing the medication, or it's a good chance to try to add on or switch to different types of medications.
Thanks, Dr. Millar. And just kind of follow up to that question about, we have a similar one about levodopa. Does levodopa lose its effectiveness over time in MSA? If so, does it make sense for the patient to stop taking it after a certain point? Dr. Millar, do you want to take that one?
Absolutely, that's a great question. And in this case, that is what happens. So like I was talking about, the problem in MSA is that it affects the structures that are receiving the dopamine. So at one point, it's not about how much dopamine you get, because all of the neurons that are supposed to get the dopamine are already receiving the dopamine, but you just haven't have enough of this structure to function properly. So the effect of levodopa may be transient in multiple system atrophy, and it does make sense to assess the response to levodopa. Levodopa is a relatively short-acting medication, so doing trials, which should be always supervised by your doctor, of discontinuing, reducing, or increasing or changing the doses of levodopa may be very useful to look at how effective it is, or if it is still effective. And this is very important with this medication because, as with any other medication, it may cause side effects as well. And at a certain point, discontinuing levodopa may actually make you feel better if it's not providing as much benefit as it provides side effects.
Thanks, Dr. Millar. I want to touch, I have a question that I would like to put to Jose, because I know you had a very important paper that came out quite recently on depression in MSA. Do you want to talk about a little bit what were your findings in that paper and how it might relate to patients?
Sure. Well, the patient looked at our MSA cohort that we had at NYU, and we conducted a self-report of depression in that population, which basically showed that in our group at NYU that we studied, close to 80% of the patients reported some type of depression, with a smaller group showing a certain level of severe depression in that group. So it basically it also showed that the depression has an effect on how patients report their symptoms. So those that were depressed compared to the non-depressed group reported higher levels of symptomology, especially in the lightheaded, the blood pressure assessments. So even though that we showed that the fall in blood pressure was no greater than the non-depressed group. So basically, the depressed group was overemphasizing their symptomology even though their blood pressures were basically not significantly different from the non-depressed group. So it basically is a concern when doing assessments and scales to know, especially for the clinician, to know whether the patients that they're being treated in their clinical trials are also having symptoms of depression, and that should be probably treated separately, but it is an outcome that has to be taken into consideration in trials.
Thanks, Jose. So if I'm hearing you correctly, what you showed was the rates of depression were actually quite high in patients with MSA. So Dr. Millar, I'm going to flip it back to you. There's a lot going on for patients with MSA, right? How can somebody tell if they're depressed or that might be contributing to the way that they're feeling?
So depression is not always about feelings of sadness, but there may be other components to it as well. As for example, it may manifest as insomnia, or as a decrease of enjoyment of activities that they usually had, or decreased social interaction and more social retraction as well. So this is always a good thing to speak to your doctor about, to try to assess, and to refer to a specialized psychiatrist if needed. And if you do, it's very good to keep communication open with your neurologist as well, as there are some antidepressants that may be very effective, but other medications may also interfere with your blood pressure control as well. So they may improve you from one aspect that may complicate your symptoms on another one. So this is very good also to open a good communication and collaboration between your doctors so they can choose the best treatment for you as well.
Thank you, Dr. Millar. That was very helpful. Keep the questions coming in. You touched in your talk about observational versus interventional studies, and you mentioned a few that were available in the local area for patients with MSA. For our audience out there, how do you decide, or how would you, what should patients do interventional studies? Should they do observational studies? Should they do both? Like, what are your thoughts on that?
This often of course, the bottom line is the patient who has the control, and it's the patient who decides what's their own perspective on the trials. So if a patient is on an interventional trial for symptomatic treatment, then there's no contraindication. There's no reason for them not to participate in the observational trial as well. Whereas if they're taking a medication that could potentially change the course of the disease, this may not be the most appropriate thing to participate in an observational trial too. But again, many of the trials that look at disease-modifying medications are also observational on their own. So they look at how the disease changes. So in a way, well, by doing an interventional disease-modifying trial, you're doing 2-in-1. But if you're participating in a symptomatic treatment trial, you can participate in an observational trial as well. And if you're already participating in an observational trial, then you can start going into a symptomatic treatment trial too. And now some patients also ask, we have interventional trials for symptomatic and for disease modifying. So which one should I get? So many times the symptomatic treatment trials are in shorter duration. Like we were talking about, we try to see changes in the least amount of time possible. And for disease modifying trials, this is usually around 1 year time. Whereas for disease modifying, this may be a couple of weeks or a couple of months. So sometimes by doing an interventional trial first, it allows you to see if this new medication may be effective for you, may be helpful. In some cases, like Jose was mentioning, if this is a repurposed medication that's already FDA approved, it may be a good way to keep on that medication after the trial is over. And then you can go on and continue with the disease modifying trial. Again, trying to maximize the potential benefit that you can get from any new medication that is available.
Thank you, Dr. Millar. So a lot of considerations there. Research has changed. I want to just touch on something that I think is relevant to all of us right now. Research has changed or has been impacted by the COVID pandemic, right? What are, I mean, you've been guiding patients through this. You've been seeing patients in the clinic, and both you and Jose have been continuing to make sure research happens. Jose, what's your thoughts on research in the time of the COVID pandemic for patients with MSA? Oh, I think we lost Jose. Patricio, do you want to take that? I'm sure Jose will rejoin us. How has research in MSA been impacted by the COVID pandemic?
So like I was talking about that earlier, as in everything during the first days of the pandemic, it was quite complicated to go through with research, and there was many adaptations that we had to go through. But there was a silver lining to this, that is that we were able to adapt much more quickly to different modalities of treatment, that if we look at retrospectively, this could have been very useful to implement earlier on, but there wasn't an increased need for that, or we just didn't saw that it may have been feasible. And by doing a lot of these visits remotely, either by having trained nurses or phlebotomists going to your home, then we're able to keep a good monitoring level to make sure that you're not having any side effects or any adverse reactions with the medications from the literal comfort of your own home. I know that this is a very used phrase, but again, and specifically for patients with multiple system atrophy that may come from parts from all over the country and who specifically have problems regarding mobilization, I think that this is very important, and it has been very helpful.
Thank you, Dr. Millar. That's incredibly useful information. Jose, can all visits be done remotely, or just some types of visits, or how can people find out about that?
Sure. Again, not all the visits will be able, but the majority, yes. The majority of visits, especially with the Theravan studies, screening, the initial visit has to be done because we obviously have to, Dr. Millar and myself have to make sure that the person qualifies to be in the study. So that visit, the initial visit, has to be done at our site. And then the remainder of the studies would be done at home with a visiting nurse coming to the person's home, also a courier service that would provide bringing whatever equipment or medication to the patient's home. And the other studies, for example, the TRACK MSA, that one obviously has to be done at site because, as I mentioned before, it requires an MRI and spinal tap, which can only be done at the hospital. So those visits need to be done there, and the other visits, the ones in between, are just scales that can be conducted via telemedicine.
Thanks, Jose. So are you, do you field many questions from people when they call in and ask about studies that address like how many visits can be done in the home versus like the number that need to be done in clinic? Is that something that you answer?
Yeah, that's a very frequent question that's posed. You know, particularly patients that have to come from quite a far distance. So we get many patients, not just from, you know, the tri-state area, but we get patients as far away as, you know, California and from other countries as well. So that's why one of the things I mentioned before is that you also want to see if especially if the study is being funded by, you know, industry, whether there is compensation for travel, because many patients need to come from out of state they need to stay at either a couple of days, so hotel accommodations, airplane flights, all those can be very costly. So some sponsors do provide very good compensation for travel. So that's one of the questions that I would be posing to a coordinator.
So thanks, Jose. If we're hearing you correctly, and like jump in if I'm not getting this right, patients can, when they participate in research, they may get some support to cover their travel expenses, but they shouldn't be paying to participate in the research. Is that correct?
Yes, correct. All research should be at no cost to the patient. You don't pay for any of the medications, for any of the study drugs. You don't pay for any of the lab fees, the MRI. All research involved participation is at no cost to the subject. And then there's also compensation for like I mentioned before, for travel and participating in the trial.
Thanks for clearing that up, because that's a very important point, right? We have a great question that came in about has any research shed light on the causes of MSA? Dr. Millar, I'm going to throw this one out to you, if you could take on that for us.
Of course, that's a fascinating subject. We've known for a number of time that MSA is caused by the abnormal aggregation of this protein called alpha-synuclein. So everyone has alpha-synuclein in their bodies, but in patients with what are called alpha-synucleinopathies, this protein starts folding and clumping in a way that starts accumulating in cells, and this is what causes nerve damage. But as with everything in science, if we start pulling the thread, we start finding more things. So we know that when the synuclein aggregates and it deposits in the cells, this triggers an inflammatory reaction. And this inflammatory reaction in turn worsens the damage to the cells and to the nervous system, and it causes further aggregation of the synuclein. We're currently looking with a group of investigators and researchers here at NYU at where does the synuclein come from? Because again, we want to treat the patients at the earliest stage possible, and we want to treat the root of MSA as closest as the root as possible. And we're trying to look at where the synuclein comes from. If the synuclein is actually synthesized by these neurons in the brain, by these cells in the brains, or is it that these kind of neurons in the brain, these cells, are taking up the synuclein as a way to clean up the mess after other cells? So we're trying to look at where the synuclein is coming from, so we can hopefully develop a compound that will target that cause and stop the production or the aggregation or the reuptake of this abnormal synuclein in place.
So we just have Jose Martinez for a couple more minutes. So if anybody has any pressing questions for Jose, please feel free to drop them in the chat or the Q&A box, and we'll be happy to get the last couple of minutes with questions with him. I just want to, what type of, you mentioned different types of trials, right? Whether they're observational, interventional, disease modifying, or symptomatic. What kind of trials, what's the name of the trials that are targeting the cause of MSA, this synuclein, this nerve loss, Dr. Millar?
So regarding interventional trials to treat the root cause of MSA, we're currently looking at trying to reduce the inflammation in the brain and trying to reduce the response of these cells that are taking the synuclein or getting damaged by the synuclein. And we're expecting in the near future to start a clinical trial with a medication that will reduce the aggregation or the amount of synuclein that is secreted for the cells to hopefully, and again, treat this condition from the very root. These medications are currently in phase 2 trials, which means that they're currently trying to look at the safety of the medication. So during this part of the trials, they usually assess for all of the clinical scales and ratings that we usually use, but their main concern is to make sure that patients do not get adverse events or side effects that could be more detrimental than beneficial for them. At the same time, they look at if there is a potential benefit for this medication and if it's worthy to move forward with it. We can't discuss this in as great detail as we want, but we think that this is very promising, and we're expecting to carry on with this kind of trials later on the year.
So, Dr. Millar, we want better treatments, right? Do you see new potential treatments in the pipeline? Are there things coming up? Have things been sort of severely impacted by COVID that research has slowed down? What's your thoughts on that?
Absolutely yes, and absolutely not. So absolutely yes, like I was talking about, basic research, meaning looking at the cells, looking at the molecules, and looking at how at the root cause of MSA is allowing us to develop specific medications and specific compounds to look at these situations and to test them and trial them in patients with multiple system atrophy. Has the research been slowed by the pandemic? Like I was saying in the beginning, it was, but in some sort of sense, it also sped up certain areas of research that have facilitated continuing trials in patients with multiple system atrophy.
Thank you. So I have just one question.
Lucy, I just wanted to touch base on a little bit of what Dr. Millar said, that at our center, we will be conducting, or we've been approached to conduct 2 new trials for the interventional studies with MSA. And those trials we're hopefully being started around June or July of this year. So, like I mentioned before, patients should definitely, frequently look at clinicaltrials.gov to see when these trials will be starting and enrollment beginning for those trials.
Thanks, Jose, for that. And stay connected also to MSA New Jersey, because when those trials open in the local area, we'll be sure to get the information out to you so you can learn more about it. And then people can call you, right, Jose, to talk about eligibility and what that might entail.
Definitely. So like you have my email there. Patients can email me, and so at least I will have their information. So as soon as these trials open up, I can email them back as far as making appointments for screening for the trials.
A quick question that came in. Do we know the name of these drugs, Dr. Millar, at this point?
Well, at this point, like we're saying, as they're experimental drugs and they're trying to determine if they're safe to be using, they're only known as numbers and letters. So they don't have, they haven't been baptized Christian yet. They don't have a proper name of their own, but we know that some of them are basically antibodies to try to reduce the burden of synuclein, or are what are called antisense oligonucleotides which target the production of synuclein within the cell.
Great, thank you for that. And one thing I think can be quite confusing is these phases of trials, right? Like, do you want to explain to us briefly what's phase 1, phase 2, phase 3 in terms of drug development?
Sure. So usually medications, they undergo various phases of development before they are finally released and approved by the FDA. So of course, in the earlier stages, the medications are tested, their biochemical properties and tested. They do what's called a proof of concept and target engagement studies. So they can make sure that the medication is doing what it's supposed to do. And these studies are usually, of course, performed in animals first. And once they have ascertained that the medications are actually doing what they're supposed to do, and they were safe in other animals to conduct with, then do you go into phase 1 or phase 2 clinical trials in subjects, in which, again, sometimes they administer the medication in healthy people, just to make sure that as this medication was safe to use in animals, it's also used to safe in people that have no other concomitant conditions that are perfectly healthy. So that's the best way to make sure that this medication will not change any other aspect of their health. And then it is administered in patients with the condition, because you know that patients with other medical conditions like multiple system atrophy, even if a medication is safe for someone who's completely healthy, this could cause some specific side effects or other problems that may be more significant to them. So again, you try to ascertain the safety of the medication, whereas at the same time, you still try to look if there's any signs of clinical improvement. So when you put together these two data, you say, okay, it's safe to go on with this medication. It's not causing any harm. There is an indication that it can provide clinical benefit. Then you go on with the phase 3 clinical trials, which you try to enroll as many patients as possible to try to identify how much clinical deficit benefit do they get, and if there's a certain group of patients in which the medication may be particularly more useful.
Thanks, Dr. Millar, for that. You know, we have we spoke about these trials being available potentially at NYU. Are there other sites around the country, around the world, that would be conducting these kind of studies, or we can only do that in our local area?
So like Jose was saying, it's always important to look at clinicaltrials.gov to look at the different sites where these trials are being conducted. So you can choose the center that's more convenient and comfortable for you to participate in.
So so where, you know, again, it's about finding that information, about finding the sites, and about finding a local investigator that you're comfortable with. That's what I hear from these conversations. So Jose, do you have, this is a question that came in about your work on depression. Do you have any ideas about how if the work on depression is going to be taken further in multiple system atrophy? I know you had mentioned that if people have more depression, they might rate their symptoms worse. But do we know how depression in somebody with MSA can affect them physically?
Well, like I was saying before, the study that I conducted showed that depression was a high percentage of patients with MSA had depression. And many clinical trials now, if not all of the ones that are being conducted, do rate in one way or another depression using different scales, using the hospital depression scale, the Beck depression scale, we also measure suicidality in all of these clinical trials now that we are conducting. So that's good to see, because now many sponsors and many industries are all monitoring and have scales to monitor depression in their patients. And as soon as someone endorses some types of symptoms, you know, the study investigators can either get more information from the patient to the severity of their depression and recommend treatment for that, either by our own doctors, by the PI, or recommend a specialist, the patient to go see a psychiatrist or so.
Thanks, Jose, for that. And, you know, I really, I want to on behalf of MSA New Jersey, who I'm representing here today, I just want to thank you for that important piece of research that you put out about depression in MSA patients and how we should be aware of it and the impact it can have on our patient population. So congratulations on your paper on that. And it was really helpful to have that out there. So, you know, it's about raising awareness. It's about, you know, participating and, you know, making sure that research can move ahead. And I'm very grateful for everything you've done for the local MSA community as well as nationally. I just, we have time. If anybody has any burning questions, like please, you know, we just have a few more minutes and then we're going to give you a break so you can get refreshed before our next session. But I would really like to thank both Dr. Millar and Jose Martinez for spending their morning and afternoon with us here at MSA New Jersey, and for being so open and willing to answer those questions. We all hope that it was a very informative session. Please, you know, any follow-up questions, any pressing things that are on your mind, you know, do reach out to us afterwards. We're in the local area and we're here to make sure that you have a channel to reach experts in MSA and get all your questions answered. So our next session is with Dr. Riddle, and we're going to touch on MSA and some of the ways in which you can help support MSA research with brain donation. So please take a moment, do whatever you need to do. We'll take a short break and we'll be back with you in 10 minutes. So on behalf of all of us here today, and thank you, Dr. Millar. Thank you, Jose.
Thank you.
Thanks, Lucy. It's always a pleasure participating in this session.